Hello everyone, welcome back to the series of lectures in cardiology. Today we'll be discussing a very important and interesting topic which is often considered to be a difficult topic by many of the students. So this is the ECG. Okay, so with the help of line diagrams and simple diagrams, let us try and understand this ECG. So we'll start off with the basics of ECG, how each of the waves in the ECG is formed, and then we will discuss the various pathologies. Okay, so let us start. What is the purpose of an ECG? So we all know that the heart's contraction is based on the electrical activity. So we have an impulse generator which is your SA node, then the impulse travels down, it causes activation of the atria, then it travels to the atrioventricular node, the bundle of His, and followed by which there is ventricular activation. So this is the pathway of the electrical activity of the heart. So, the electrical activity of the heart, is recorded using electrodes. Where are these electrodes placed? They are placed on the body surface. So, these electrodes which are placed in various positions determine the electrical activity of the heart by seeing the heart from different directions. Okay, so this is the basic purpose of the ECG. So, whenever there is a pathological process that is going on, the ECG will show different directions and different deflections. So, this is the purpose of an ECG. Okay, so what does the ECG stand for? It stands for Electrocardiogram. It stands for Electrocardiogram. So, it records the electrical activity of the heart in the form of graphs. Alright. Okay. Now, let us understand what is a lead system. So, by definition, a lead is basically defined as an imaginary line. A lead is defined as an imaginary line that connects two electrodes. It is defined as an imaginary line that connects two electrodes. Okay. So, let us understand this with this diagram. Okay. Now, this is your heart. With the heart in the center, we try to place two electrodes. So, we have one electrode which is connected to the left arm and we have another electrode which is connected to the right arm. So, by convention, the electrode which is connected to the left arm is connected to the positive pole of the galvanometer. So, galvanometer is basically the device which identifies the electrical activity and records the electrical activity. So, by convention, the electrode which is connected to the left arm is connected to the positive pole of the galvanometer, and the electrode which belongs to the right arm is connected to the negative pole of the galvanometer. It is connected to the negative pole of the galvanometer. Okay. And the net electrical activity between these two electrodes is denoted by a lead. Okay. So, this is what is a lead. Now, we all know that from your basic physics that every activity or electrical activity is denoted by a vector, and a vector has a direction. So, if the electrical activity is flowing towards the positive electrode, flows towards the positive electrode, then this will be detected as a positive deflection on that particular lead. Similarly, if the electrical activity moves away from the electrode, so if you are looking at this lead and the flow of the electrical activity is in this direction away from the lead, then this is recorded as a negative. So, if electrical activity flows towards an electrode, it is a positive deflection. If it flows away from an electrode, it is a negative deflection. So, till now clear? We have learned what is an ECG, we have learned what is a lead, and we have learned what is a positive deflection and a negative deflection. Okay. Now, the leads are classified into two types. Leads are classified into two types as bipolar leads and unipolar leads. as bipolar leads and unipolar leads. Now we'll understand how these bipolar and unipolar leads are constructed. Okay. So what is the meaning of bipolar lead? A bipolar lead means that two electrodes are involved in the construction of the lead. So two electrodes are involved in the construction of the lead and both of them record the electrical activity. Okay, and both of them record the electrical activity. Okay, so let us look at the first lead. So here the lead is constructed between what? Between the left arm and the right arm. The lead is constructed between the left arm and the right arm. The left arm is connected to what? The positive pole of the galvanometer, and the right arm is connected to the negative pole of the galvanometer, and this is what we call as a lead 1. Okay, and these are connected to the limbs and hence they are called as the limb leads. They are called as the bipolar limb leads. Okay, fine. Let us look at the next diagram. How is this lead connected? This lead is connected by joining the right arm. This lead is connected by joining the right arm and the left foot. It is connected by joining the right arm and the left foot. Okay. So the left foot is connected to the positive pole of the galvanometer and the right arm is connected to the negative pole. So a lead which is obtained in this way is called as lead 2. Okay, so this lead is called as your lead 2. Now how do you construct your next lead? So this lead is connected between the left arm and the left foot. Left arm and the left foot, and this is what we call as the lead 3. Lead 3. Okay, so we have understood what are bipolar leads, and these are limb leads because they join the limbs. So lead 1 is between the right arm and left arm, lead 2 is between the right arm and left foot, and lead 3 is between the left arm and left foot. So this is about your leads 1, 2 and 3. Fine. Now if you take the directions of these vectors, you are forming a triangle with the heart in the center. This means that the electrical activity of the heart is recorded using this triangle, using these 3 leads. So this is your lead 1, yes, this is your lead 1, this is your lead 2 and this is your lead 3. So this triangle that is constructed is called as your Einthoven triangle. Okay, so this is what is called as your Einthoven triangle. Fine, but we also know that a vector always has a magnitude and a direction. So how do we give this direction to the vector? Now let us look at that. So this triangle constructed by using the leads 1, 2 and 3 is your Einthoven triangle. Fine. Now let us construct something by combining the leads at the midpoint. We will combine the leads at the midpoint. Okay. Now let us see that. How do we do that? So this is your lead 1. Okay. You take it here. Fine. You take it here. Now you take your lead 2. You take your lead 2 and you take your lead 2 and combine it at the center with lead 1. Then you take your lead 3 and you combine it at the midpoint like this. Okay. So what are you getting here? So what are you getting here? This is your lead 1, this is your lead 2 and this is your lead 3. When you combine it at the midpoint, you get something called as your triaxial reference system. Your triaxial reference system. Okay. And you give them direction in terms of angles. right? So it's very easy to understand now that the lead one is between 0 to 180 degree. It is between 0 to 180 degree. Fine. By convention, you just give a minus and a plus. So something above is denoted by minus and something below is denoted by plus. Okay. Now, you know that lead 2 is between what? It connects plus 60 degree and minus 120 degree. And lead 3 is what? Lead 3 is between minus 60 degree and plus 120 degree, right? 60 degree from where? 60 degree from the horizontal, 120 degree from the horizontal. Okay. So, this is what is your triaxial reference system. Fine. I hope this is clear now. We have understood how each of the leads are constructed. So, a lead is basically an imaginary line that connects two electrodes. You place two electrodes, one connected to the positive pole, other connected to the negative pole. And the electrical activity of the heart is recorded. So, it is recorded in the form of what? It is recorded in the form of vectors. So, vector is something that has a magnitude and direction. So, each of these leads, when you combine it, they form a triangle which is called as a Einthoven triangle. Now, you take this and combine it in the midpoint, you get something called as a triaxial reference system with a direction. Okay. So, the whole point is that we represent the leads in this way so that whatever deflection you get it with an angle and direction, and you can then find out what the pathology in the heart is. That we will be looking at when we are discussing further. Okay. So, this is about your bipolar limb leads. Now, let us look at what is a unipolar limb lead. Let us look at what is a unipolar limb lead. Now, as the name suggests, the electrical activity is recorded by only one electrode, which is the exploring electrode. And there is another electrode which is called as the distance or ground electrode, which does not detect any deflection. There is a distant or ground electrode which does not detect any deflection. Okay. So, let us just understand how this is constructed. So, there are three unipolar leads. So, they are also limb leads. So, one basically detects the direction of flow towards the right shoulder. Okay, the other was right arm and left foot. So, this is your right shoulder, the other is towards your left shoulder, and the other detects the deflection towards your left foot. Okay, it detects the deflection towards your left foot. Okay, now if you are taking the lead which is detecting the direction of the electrical activity towards your left foot. Okay, so how is it connected? This is connected to the positive pole of the galvanometer. The exploring electrode is connected to the positive pole of the galvanometer. Okay, the other electrode, which is your distant or ground electrode, is connected through a resistance of 5000 ohms. Then it is connected to a central electrode, and then it goes and connects to the negative pole of the galvanometer. Okay, so this is just a basic understanding of how an electrode is constructed. So, the exploring electrode, let us say, is connected to the left foot, it is connected to the positive pole, and the ground electrode will be connected through a central electrode to the negative pole. Fine? Okay. So, what is the name of the leads that are generated through this? This is called as the VR, the VL and the VF leads. The VR, the VL and the VF leads are the unipolar limb leads, whereas leads 1, 2 and 3 are bipolar limb leads. Okay. But what they found is that these deflections which were obtained using construction of these leads are very small. Okay. So, what they did is that they just removed or disconnected the ground electrodes, and they found that the voltage of the deflections increased by 50%. So, when you just disconnect it, they found that the voltage in these leads increased by 50% and you could read it better. That's the reason why they have named it as AVR, AVL and AVF, which means augmented limb leads, augmented unipolar limb leads. Okay, what is the augmentation? There was just a small change in how the electrodes are connected so that the voltage appears higher. Okay, so we can say that the AVR detects the electrical activity towards the right shoulder, the AVL detects the electrical activity towards the left shoulder, and the AVF detects the electrical activity towards the left foot. Okay, so that is about your unipolar limb leads. So what is this? This is your AVR, okay, which is towards minus 150 degrees, AVL towards your minus 30 degrees, and AVF towards plus 90 degrees, okay. So now we will try and combine the unipolar and the bipolar limb leads in terms of their vectors and direction, okay. So if you combine your unipolar and bipolar limb leads, what will you get here? So how many leads? 3 leads in your unipolar limb leads, 3 leads in your bipolar limb leads, and this is what we call as your hex axial reference system. This is what we call as your hex axial reference system. Okay, fine. So we have already seen, right? We have already seen here, this is just for your comparison. So we have seen here how are the leads 1, 2 and 3 constructed. 1 is between 0 and 180 degree, 2 is between minus 120 and plus 60 degrees, and 3 is between plus 120 and minus 60 degrees, right? To this we add the directions of AVR, AVL and AVF. Okay, so that is denoted by your blue color. Okay, so the blue color here basically represents your augmented limb leads, unipolar limb leads, right? So what is the direction? Now we know that AVR is towards the right shoulder. So this is your minus 150 degrees. AVL is towards your left shoulder and AVF is towards your plus 90 degrees. So with the help of these 6 limb leads, you can find the direction of the electrical activity of the heart, and this is obtained using which plane? So these limb leads sees the direction of electrical activity of the heart in the supero-inferior direction, which is called as the frontal plane. So this plane is what we call as the frontal plane. Okay, so can you just see here how each of these leads are looking at the heart? So if the heart is in the center, and you connect all these leads, so you can see that the AVR sees it in this way. The AVR looks at the heart in this direction. So we can see here that the AVR sees it at minus 150 degrees. So AVR is looking at the heart in this direction. The lead 3 is looking at the heart in this way, right? So it's looking at the heart in this way. AVF is seeing the heart from down from the foot at 90 degrees. Lead 2 is looking again at the inferior aspect at an angle of 60 degrees. Lead 1 is looking at the heart from 0 to 180 degree direction, and lead AVL is looking at the heart from above at minus 30 degrees. Okay, so the entire heart in the frontal plane is looked upon. I would say looked upon because if the direction of electrical activity in these leads will help you understand how the heart has moved or shifted, which we call as the axis. Okay, so in certain pathologies, the heart can move towards the left. Like if you have a left ventricular hypertrophy, the heart which is like this, because the electrical activity or the vector will be more if there is a left ventricular hypertrophy, because the left ventricle is much more higher in mass. So the heart might move leftward, right? So the deflections will be higher in these limb leads which are looking at the heart from the left side. Okay, so this is the basic fundamental principle of construction of these unipolar and bipolar limb leads. Okay, so I hope you have understood this with the help of this diagram. Now, let us look at what are chest leads and how are these constructed. Okay, so the aim of these chest leads is that they see the heart in this horizontal plane. Can you see here, if this is the heart, they see the heart in a horizontal plane. Okay. So, the limb leads look at the heart in the frontal plane, whereas the chest leads look at the heart in the horizontal plane. Okay. So, what are the chest leads? We have V1, which is present here. This is your right fourth intercostal space on the right side, on the right parasternal area. V2 is in your left fourth intercostal space, on the left parasternal area. Okay, let us come to V4 and go back to V3. V4 is in your left fifth intercostal space in the mid clavicular line. Right? So, V3 is between V2 and V4. Okay. V5, as you can see, is in the left fifth intercostal space. It is in your left fifth intercostal space, where in the left fifth intercostal space in the anterior axillary line. Okay, whereas V6, it's in the left fifth intercostal space in the mid axillary line. Okay, so you have understood where is V1, V2, V3, V4, V5 and V6. So, these are your main 6 chest leads. Now, can you see here something called as V3 and V4 are? So, V3 and V4 are in the left side. Diametrically opposite to that is your V3R and V4R, which are your right-sided leads. Right-sided leads are not there in your normal ECG or regular ECG, but you can construct right-sided leads, and these help in detection of what? RVMI. These help in detection of what? RVMI. Okay. Then what is this on the posterior aspect? Which ball is not well represented in a normal ECG? In your normal ECG, do you see posterior lead? No. Your posterior wall is not well represented in your normal 12 lead ECG. That is why you would have to ask for a posterior leads in case of a posterior wall MI. So, if you are suspecting a posterior wall MI, you ask for posterior leads. Okay. How are these posterior leads constructed? So, we have V7 in the posterior axillary line. Then we have V8 just below the scapula, infrascapular, and we have V9 in the paraspinal region. Okay. So, if there is ST segment elevation in V7, V8, V9, it is your posterior wall. But can you find the posterior wall MI in your normal ECG? Yes, you can look for reciprocal changes. So, which leads are diametrically opposite to V7, V8 and V9 anteriorly? That is your V1, V2 and V3. So, this is opposite to V1, V2 and V3. So, if you have an ST segment elevation in V7, V8 and V9, what are you expecting here? You will have ST segment depression in V1, V2 and V3. So, if you have significant ST segment depression in V1, V2 and V3, then you consider a posterior wall MI. Or in other words, the ST segment elevation in V1, V2, V3, if you flip it upwards, what does it look like? ST segment elevation where? In V7, V8 and V9. So, that is about your chest leads. So, with this, what have we understood? Let me just recollect it for you. We have understood what is a lead system, how do we construct a lead, what are bipolar limb leads, what are unipolar limb leads, and how do you construct a chest lead. So, we have understood what is a triaxial and a hexaxial reference system. So, this is your hexaxial reference system. Okay. So, till here understood. Now, let us move on to the next question. The next question is, what is a standard ECG? So, let us understand how is the ECG paper constructed and what do you mean by a standard ECG. Okay, fine. Now, let us look at the ECG paper. So, can you see in the ECG paper, basics you will be knowing that you have the deflections, which is your P wave, QRS complex and your T wave. Now, if you look at the ECG strip, you can see that there are darkened lines. Okay. Now, each dark line, the area which is between each dark line is what we call as a big box. Okay, fine. Now, you enlarge this big box. This is what I have drawn here. So, you enlarge this big box. So, each big box has how many small boxes? They have 5 small boxes. Okay, they have 5 small boxes. Now, what is the dimensions of each small box? So, each small box is 1 mm by 1 mm. Okay, so your ECG paper has multiple big boxes. Each big box has 5 small boxes, and what is the dimension of each small box? It is 1 mm by 1 mm. Okay, now let us understand what is standardization or calibration. Okay, so what is standardization or calibration? So in an ECG paper, at the end, in the bottom, you find this kind of a diagram. You find this kind of a diagram which is denoted at the bottom half or at the bottom of every ECG paper. What does this mean? This means that every 10 mm deflection is 1 millivolt. That means every 10 mm, that means that every 10 small boxes is 1 millivolt. Right? That means what? Every 10 small box is 1 millivolt. Okay. That means one small box, the height of one small box is how many millivolts? It is 0.1 millivolt. 0.1 millivolt. Okay. So, this is what you mean by a standard ECG. Standardization or calibration means that the ECG machine is calibrated such that the ECG paper is in this way and every deflection is of the same quantity. Okay. So, every 10 mm deflection means 1 millivolt deflection. Okay. So, that means every small box has a height of 0.1 millivolt. Okay. And how do you know the horizontal? So, how do you know your horizontal calibration? Okay. So, to understand this, we know that the speed of the ECG paper. So, you have to understand the speed of the ECG paper. So, the speed of the ECG paper. So, when you are drawing out the ECG paper from the machine, the speed is 25 millimeters per second. Speed is 25 millimeters per second. So, that means that what? So, each 1 mm. So, how much will be 1 mm? 1 mm width will be 1 by 25, right? So, the speed is 25 millimeters per second. That means that 25 millimeters is covered in 1 second. So, 1 mm width is how much? In terms of seconds, it is 1 by 25 or 0.04 seconds. Okay. So, we know that each small box is 1 mm by 1 mm. So, we have understood that 1 mm height is what? 1 mm height is 0.1 millivolt. 1 mm height is 0.1 millivolt and 1 mm width is 0.04 seconds. Right? I hope you have understood this. Okay. So, how did we derive this? Let us just go through this again. So, each ECG paper has many large boxes which are given by these dark indentations. Okay. Each large box, if you enlarge and see, you have small boxes. Each small box is 1 mm by 1 mm. Okay. Now, how do you know what the width and the height stands for? So, the height basically refers to the deflections. Now, every ECG paper is standardized such that 10 mm deflection is equal to 1 millivolt. So, 1 mm is what? It is 0.1 millivolt. It is 0.1 millivolt. Okay. The width, how do you obtain? The width is basically given by the speed of the ECG paper. So the speed of the ECG paper is such that it covers 25 mm in 1 second, right? So what is the time for each of these small boxes? It is 0.04 seconds. Okay, or in other words, you multiply it by 5, you will get it for the large box. So the large box, the height is 0.5 millivolt, width is 20 milliseconds. Okay, so this is your standard ECG. You have understood what are the dimensions of each of the small and big boxes. Okay, now let us move to the next question. We'll understand what are the waves of the ECG. So we know from our basic physiology that there is a P wave, there is a QRS complex, and there is a T wave. So we have a P wave, QRS complex and T wave. Okay, so what is the P wave due to? P wave is due to atrial depolarization. Okay, atrial depolarization causes the P wave. The QRS complex is due to ventricular depolarization. It is due to ventricular depolarization. What is the T wave? T wave is due to ventricular repolarization. Repolarization. So this is your atrial depolarization, ventricular depolarization and ventricular repolarization. Okay. Now, basic thing is that you should know that the action potential is what is responsible for the ultimate electrical activity and muscle contraction. So, let us corroborate the ECG findings with the waves on the action potential. Okay. So, the resting potential is at minus 90 millivolts. So, this is your ventricular action potential. This is your ventricular action potential. Okay. So, what is the first phase? The first phase is your phase 0. So, in your first phase, what happens? There is a activation of a fast sodium channel. Okay, so there is activation of a fast sodium channel. So, what happens is that the intracellular becomes more positive. So, there is inward movement of the sodium and there is also a slow calcium channel inward movement. Okay, so the sodium and calcium enter into the cell. So, when sodium and calcium enter into the cell, more positivity, what is this recorded as? This is your phase 0, which is positive and goes up to plus 20 millivolts. Then you have a slightly negative deflection, which is your closure of your sodium channel, which results in phase 1. Now, if the sodium channel gets closed, there is some positivity, but now there is some positivity, the sodium channel gets closed and potassium that was inside is going outward. That means what? There will be some amount of negativity as well because positive ions are getting lost. So, this is recorded as a negative deflection. Now, what happens in phase 2? There is continued opening of the calcium channel. We had already seen that there was an inward opening calcium channel. There was an inward opening calcium channel which was already open. This is your sodium channel and this is your potassium channel. Now, first sodium had moved in, calcium moved in, so it was positive. Then potassium started moving out, so it was slightly negative. Now, what happens is that this is closed. Okay, so your sodium channel is closed at this time. Now, what happens is that the potassium continues to move out, the calcium continues to move in. Since it is a slow channel, this balances each other and it results in your plateau phase. It results in your plateau phase, which is your phase 2. In phase 3, there is inactivation of your calcium channel. So, what happens is that the calcium channel also gets inactivated. So, sodium channel gets inactivated, calcium channel gets inactivated. The potassium flux continues outwards. So, the potassium is continues to go outwards. That means what happens to the membrane inside? Positive ions are going out, it becomes negative. So, this is your phase 3, which is characterized by a negative dip. Okay. So, you understood the mechanism of action potential. Now, how does it correlate with your ECG? So, phase 0 means what? The ventricle is getting depolarized. So your phase 0 and phase 1 basically represent your QRS complex. Your phase 0 and phase 1 represent your QRS complex. It represents your QRS complex. Phase 2 is isoelectric. So do you think there will be any deflection on the ECG? No, this is deflected as an isoelectric line, which is your ST segment. Fine. Now, phase 3 represents ventricular repolarization, and this is denoted by your T wave. Okay. So, phase 0 and phase 1 corresponds to QRS complex, phase 2 is your ST segment, and phase 3 is your T wave. Now, let us understand this concept of refractory periods. Let us understand this concept of refractory periods. So, in phase 1 and phase 2, there can be no electrical activity, or if there is an impulse even in this phase, the segment remains absolutely refractory and there cannot be any contraction. Okay. In phase 3, if there is an impulse that comes, there is an effective refractory period. So, in effective refractory period, if there is an impulse, there can be an impulse generated, but that will be very, very weak. In phase 3 and in your later half of phase 3, your effective refractory period is in your early half. In the later half of phase 3 and in your phase 4, you have your relative and supernormal refractory period. So, in this, what it means that if there is an above normal stimulus which comes and falls in your late part of phase 3 and phase 4, then you can trigger an electrical activity. So, that means that suppose there is a VPC or a ventricular premature complex. Why is it premature? Because it was not supposed to arise in this time, but it has arisen during this relative or supernormal refractory period, then it can result in an arrhythmia. So, any stimulus that acts on the phase 3 or 4, late phase of 3 and more often in the phase 4 can result in or can trigger in an arrhythmia. Okay, fine. So, that is about the different waves and its correlation to the action potential. Now, okay, let us move on to the next question. How are the waves produced? Okay, how are the waves produced? So, this is a line diagram showing the conduction system of the heart. So, this is your SA node. So, when the electrical activity comes from the SA node, so what happens? It basically, so first it depolarizes the right atrium and then it depolarizes the left atrium. Okay, so we repeat that. When the impulse comes from the SA node, it first depolarizes the right atrium and then depolarizes the left atrium. So, how is this deflected as? On the ECG, it is shown by an upstroke, which is the first half of your P wave, So, the first half of the P wave is because of right atrial depolarization and the next half is because of your, so the impulses are produced from the SA node. So, once the impulses are produced from the SA node, there is contraction of the right atrium followed by contraction of the left atrium. So, there is contraction of the right atrium followed by contraction of the left atrium. So, this contraction of the right atrium is denoted by the first half of the P wave. We know that the P wave is because of atrial depolarization. So, the first half is by the depolarization of the right atrium and the second half of the P wave is by the left atrium. Okay. Now, this is best recorded as a positive wave in lead 2. Okay. So, this is best recorded as a positive wave in lead 2. In V1, normally the P wave is biphasic. In V1, in lead V1, a normal P wave is biphasic. Can you see? Biphasic this way. So, this is by the right atrium and this is by the left atrium. Fine. So, what is a normal P wave? A normal P wave has a width of less than 2.5 small boxes and a height of less than 2.5 small boxes. Okay. So, this has a width of less than 2.5 small boxes and a height of less than 2.5 small boxes. Now, once the impulse has depolarized the right and the left atrium, the impulse then moves where? To the AV node. The impulse then moves where? To the AV node. So, the P wave is formed. Now, will the AV node cause any deflection on the ECG? No. So, it results in an isoelectric segment which is called as the PR segment. Okay, this is called as the PR segment. Fine. Now, followed by the AV node, there is conduction down the bundle of his and the right and left nodal branches. So, even conduction down the bundle of his is again recorded only as your PR segment, followed by which there is activation of the ventricles, right. So, there is activation of the ventricles. So, the activation of the ventricles is what results in the next complex, which is your QRS complex, So, understood till here? So, right atrium and left atrium is your upstroke and downstroke of P wave. Then the rest of it is your PR segment, where they remain isoelectric at the SA node and bundle of his. Activation of the ventricles is brought about as the QRS complex. Fine. Now, let us look at the QRS complex in detail. What is the sequence of activation of the ventricles and how are the QRS complexes formed? So, the sequence of activation of the ventricles is by these three steps. So, the first part which will be activated is your septum. Followed by activation of the septum, there will be activation of the ventricular walls. Followed by which there will be activation of the base of the heart. So, depending upon the direction of the electrical activity, the QRS complex will be different, or the morphology of the QRS complex will be different in different leads. Let us understand this how. Now, the heart is represented here, right. So, where is the lead V1? The V1 basically looks at the septum, right. The V1 basically looks at the septum and the V5, V6 are the lateral leads. So, how is the QRS complex morphology different in V1 as compared to V5, V6, right. So, let us look at V1. So, in the V1 lead, what is the first part of the ventricle which will be activated? It is the septum, correct. This is the septum. What is the direction of electrical activity? It is towards the septum. So, if any electrical activity is towards a lead, so how will it be represented? It is represented as a positive deflection called the R wave. Okay. The second will be the activation of the ventricle. So, what is the direction of the activation? It is away from the lead V1. So, it will be recorded as a negative deflection. So, in lead V1, because the direction of activation is towards the lead, you will first have a positive deflection and then you will have a negative deflection, and this is what we call as a RS wave. We will be looking at how we came up with the naming of R wave, S wave, etc. But this is the basic concept behind the QRS complex morphology in lead V1. Now, let us see how the QRS complex morphology will be different in lead V5. Now, where is this lead V5? It is looking at the heart from the lateral aspect, right? So, now first activation will be activation of the septum. This is away from V5 or towards V5? It is away from V5. So, activation of the septum will be represented as a negative wave. So, can you see the difference? In V1 you will first have a positive deflection, but in V5 you will first have a negative deflection. Okay. Then activation of the ventricular wall. Activation of the ventricular wall is towards V5, so you will get a positive deflection. Okay. Then you have activation of the base, which is away from V5, so you get a negative deflection again, right? So, this basic difference in the morphology of QRS, what do you mean by this? So, I can say that as you move from V1 to V6, what will happen in a normal ECG? So, what happens is that when you move from V1 to V6, the R waves become larger. Can you see here? Here they are very small R waves. But when you come to V5, the Lahr waves become larger. Okay, so this is what we call as the normal progression. So can you see here in this normal ECG, there are S waves. The S waves become smaller and smaller. So S waves become smaller and smaller as you go from V1 to V6, such that there are no S waves left, and the R waves become larger and larger. Okay, they become taller and taller. So this is what we call as a normal R wave progression. Okay, so this is what we call as a normal R wave progression. So if this does not happen, this is called as a poor R wave progression, which you see after post myocardial infarction. So that is about your normal R wave progression. Okay. So what is a normal QRS complex? A normal QRS complex duration is 0.06 to 0.10 seconds. And what is a normal height? Normal height of the QRS complex is more than 5 mm in limb leads and more than 10 mm in chest leads. So this is your normal QRS complex width and height. Let us look at the nomenclature. Let us look at the nomenclature of a QRS complex. Okay. So after the P wave and the PR segment, if you have the first negative wave, if you have a first negative wave, it is denoted by Q or Q. It is denoted by Q or Q, which is a small q or a capital Q. The first positive wave after a Q or Q wave, the first positive wave is denoted by R. The first negative wave after the R wave. Okay, so you have a first negative wave which is a Q wave. Now, after the first negative wave, you have a positive wave which is your R wave, and this is your R wave. After the first negative wave and positive wave, you again have a negative wave, then this is denoted as an S wave. Okay. Now, a first positive wave after the S wave is called as an R prime wave, and any first negative deflection is given by your Q wave. Okay. Fine. So, let us just look at this. This is a positive deflection, so it is denoted as R. Okay, you have a negative followed by a positive, so this is your QR. Now, you already have a positive, so that is an R, it is not a Q, because negative deflection is denoted by a Q, and any deflection, any negative deflection after an R wave is called as your S wave. Fine. Now, these are only positive, there are no Qs, so you have the first positive which is an R, and you have a second positive. If you have a second positive, it is not a Q or an S, it is an R prime. So, this is how you denote the various morphologies of the QRS complexes. So, I hope it is clear till here. Now, let us understand the next question. What are segments and what are intervals? Okay, fine. So, what is a segment? On the ECG, isoelectric lines which do not include any waves. Isoelectric lines which do not include any waves. These are called as segment. So, can you see here you have a PR segment between the P wave and the QRS complex, and you have an ST segment between the QRS complex and the T wave, and you have a TP segment between the T and the next P wave. Okay, so this is your PR segment, ST segment and TP segment. What is an interval? A segment along with the waves is called as an interval. So, PR interval is basically from the beginning of P wave to the beginning of QRS complex. So, from the beginning of P wave to the beginning of QRS complex is your PR interval. What is a QT interval? From the beginning of Q wave. So, the beginning of Q wave to the end of T wave. Okay. So, what is a QT interval? The interval between the beginning of the Q wave to the end of the T wave, which includes the QRS complex and the T wave, is called as a QT interval. Okay. Fine. Now, what is a J point? So, what is this J point? The point at which the QRS complex ends at the ST segment begins. The point at which the QRS complex ends and the ST segment begins is called as your J point. Okay. And what is a U wave? In some individuals, you can have U wave which is generated because of repolarization of the bundle of His. So, in some individuals, you can have a U wave which is generated because of repolarization of the bundle of His, and this is what we call as a U wave, and it can be seen in hypokalemia. So, this can be seen in hypokalemia. Okay. So, this is about your various segments and intervals. Fine. So, what is your normal PR interval? A normal PR interval is 0.12 to 0.2, which is 3 to 5 small boxes. Okay. What is a normal QT interval? So, it can be from 350 to 440 milliseconds. So, anything more than 440 milliseconds in males and more than 460 milliseconds in females is your long QT. It's your long QT. Okay. So, this is your long QT. Fine. So, now we have understood about segments and intervals. You have to remember what is your normal PR segment, what is your long QT, what is your normal QT, and what are the various other waves including J point and U waves. Now, let us look at what are the abnormalities which can be seen. Let us look at what are the abnormalities which can be seen. So, what are the abnormalities which can be seen? Fine. So, we look at the abnormalities of P wave. So, we know that the P wave is because of atrial depolarization. The first half is because of right atrial depolarization. Second half is because of left atrial depolarization. Fine. So, in lead 2 and V1, you have in lead 2, you have a single positive P wave, and the P wave is best appreciated in lead 2 followed by lead V1, and in lead V1 you have a biphasic P wave. So, that is normal, we have already looked at that. Now, what is this? The height of the P wave. The height of the P wave is more than 2.5 small boxes. We have know that the normal height of the P wave is less than 2.5 small boxes. Height has increased, or in the lead V1 you see that the first positive deflection is much taller. So, this is what we call as the P pulmonale. This is what we call as the P pulmonale. Okay. So, this is what we call as the P pulmonale. Okay. So, let us look at the ECG here. Can you see that the P waves are much taller? The P waves are tall. So, you have tall P waves which are more than 2.5 small boxes. If you just count here, can you count here? This is 1, 2, 3. So, more than 2.5 small boxes. This is what we call as your P pulmonale. And where do you see this P pulmonale? P pulmonale is seen in pulmonary hypertension. Right. So, the P pulmonale is seen in pulmonary hypertension. What is the second abnormality of P wave you can find? You can find that the P wave width in lead 2 is more than 2.5 small boxes, or the negative deflection in lead V1 is much deeper. The negative deflection in lead V1 is much deeper. So, this is what we call as your P mitral. This is what we call as your P mitral. Okay. So, let us look at this ECG. Can you see here that there is some humping of the P wave like this? Okay. And the width is also definitely more than 2.5 small boxes. If you look at V1, the negative deflection is more prominent. Can you see here? The negative deflection is more prominent. And this is what we call as your P mitral. And where do you find this P mitral? P mitral is seen because of left atrial enlargement in mitral stenosis. Left atrial enlargement in mitral stenosis. Fine. So, P pulmonale is called so because it is because of right atrial enlargement. So, in pulmonary hypertension, you can find right atrial enlargement. So, this is about the abnormalities of P wave. Okay. Now, next is your PR interval. Next is your PR interval. So, in PR interval, what you should be worried about is your short PR interval. A normal PR interval is 0.12 to 0.2 milliseconds. So it is 0.12 to 0.2 milliseconds. So when it's less than 0.12, less than 3 small boxes, then it's called as a short PR interval. Why are you worried about a short PR interval? Because this can be seen in tachycardias, especially your supraventricular tachycardias. A short PR interval basically means that the patient is at an increased risk of supraventricular tachycardias, including WPW syndrome, and an increased risk of fatal arrhythmias. That is the reason why your PR interval you should be focusing on. Okay. Now, let us look at the QRS complex. So, when it comes to the abnormalities of the QRS complex, when do you call it a prolonged QRS complex? When the width is more than 0.1 seconds, when the width is more than 0.1 seconds. So, if the width is more than 0.1 seconds, you call it a prolonged QRS complex. So, QRS complex is as a result of what? It is as a result of ventricular depolarization. So, which are the conditions where this ventricular depolarization will be delayed? So, can you see that in conditions where there is an increased LV mass? So, this is your LV, right? So, in conditions where there is an increased LV mass, what happens to the electrical activity? It takes more time to depolarize because it has to go to muscle conduction and then depolarize. So, in conditions where there is an increased ventricular mass, you will have a wide QRS complex. Also, when there is a delay in activation, right, there is a delay in activation. Now, you know that the electrical activity is brought about by the bundle of His, and this is your left and this is your right bundle branch. So, this is your left and right bundle branch. So, if there is a block here, if there is a block here, then what happens? There is a delay in the conduction. So, what happens to the QRS complex when there is a delay? Again, there will be a muscle to muscle conduction, and this will result in a widening of the QRS complex. Then, the third condition where you can have a wide QRS complex is in your ventricular arrhythmias. So, normally your SA node, normally the electrical activity is from the SA node to the AV node to the ventricles. So, if the impulse is directly originating from the ventricle itself, you will have a wide QRS complex. Okay. So, increase in muscle mass is seen in conditions like left ventricular hypertrophy. Delay in activation is seen in conditions like left bundle branch block. Okay, in left bundle branch block. Okay. Now, we look at the amplitude of the QRS complex. So, when do you call it a low voltage QRS complex? When the amplitude is less than 5 mm in the limb leads or less than 10 mm in the chest leads. Okay. So, less than 5 mm in the limb leads or less than 10 mm in the chest leads, we call it a low voltage complex. So, where do you find these low voltage complex? You find it in conditions where the electrical activity is not well recorded. So, you can see it in obese individuals, you can see it in COPD. So, you can see it also when there is pericardial fluid or fluid around the heart. So, it is also seen in pericardial effusion. Okay. Now, increased voltage. When do you have an increased amplitude of the QRS complex? That means what? The electrical activity is getting conducted well. That means what? When do you get an increased electrical conductance? When there is enough blood in the ventricle, right? So, when there is enough blood in the ventricle, the QRS complex voltage becomes higher, and this is what we call as the Brody effect. So, where do you find this Brody effect? So, this Brody effect is seen in conditions where there is a volume overload state. Okay, so you can see a large QRS complex where there is a volume overload like in VSD or in AR or in MR. Okay, so you will find large QRS complexes. Fine? Okay, so that is about your QRS complexes. Now, let us look at the QT interval. So, a QT interval is basically the interval from the beginning of the Q wave to the end of the T wave. Okay. So, a normal QT interval is 350 to 440. If it is more than 440 milliseconds in men and more than 460 milliseconds in women, we call it a long QT syndrome. Now, remember that the QT interval is dependent upon heart rate. Okay. So, the QT interval is dependent upon the heart rate. That is the reason why you have to correct the QT interval to the heart rate. So, this is given by the formula which is called as the Bassett's formula. This is given by the formula which is called as the Bassett's formula. So, QTC is given by QT by root over of RR interval. Okay. So, QT by root over of RR interval. Now, let us look at the causes for prolonged QT. The prolonged QT can be due to genetic as well as acquired causes. The genetic causes are called as your congenital long QT syndrome. LQT stands for long QT syndromes. Okay, they are congenital. They are of different types. Type 1 is due to a potassium channel defect. Type 2 is also due to a potassium channel defect. Type 3 is your sodium channel defect. These two are potassium. This is your sodium channel defect. Fine. So, that is about your congenital long QT syndrome. Always remember, there can be acquired long QTs as well. There can be acquired long QTs predominantly because of drugs. So, the drugs which cause this are the antibiotics such as quinolones, and then you have trimethoprim, macrolides, famous one being your azithromycin. Okay. Antifungals, especially the azole group of drugs. Then you have your SSRI and TCA, and antipsychotics like haloperidol and antiemetics like ondansetron, and which antiarrhythmics are associated with long QT, which is your class 1A and class 3 antiarrhythmics are associated with your long QT syndrome. Now, why are we so bothered about this long QT? Because a long QT, what happens is that the next impulse which falls on the long QT can result in, or it can trigger an arrhythmia which is called as a type of ventricular arrhythmia, which is your torsades de pontis, Fine. Now, let us just look at this ECG. Can you see that the QT is definitely prolonged? Okay, it is definitely prolonged. So, this is about your long QT. Now, let us look at the next portion, which is your J point. So, J point, as we have learned, is the point at which the QRS complex ends and the ST segment begins. So, J point elevation is important because in certain conditions the J point can get elevated and you can identify which condition it is. So, the epsilon wave is a J point elevation which is seen in arrhythmogenic right ventricular dysplasia. Okay. So, that is your epsilon wave. In this ARVC, the right ventricle is not well developed and you find a lot of variations in the right ventricle and it predisposes to arrhythmias. The Osborn wave is a J point elevation which is seen in hypothermia. The Osborn wave is a J point elevation which is seen in hypothermia. Okay, fine. Now, let us look at the abnormalities of the ST segment. Now, normally, in normal individuals, there can be a mild ST segment elevation in leads V1 to V4, especially lead V2. And this is what we call as the early repolarization syndrome. So, there is an early repolarization and the ST segment appears minimally elevated. Now, what is abnormal? Abnormal is J point elevation more than 1 mm in 2 consecutive leads. J point elevation which is more than 1 mm in 2 or more consecutive leads, then it is abnormal. In leads V2 and V3, more than 2 mm in males and more than 1.5 mm in females. Okay, more than 2 mm in males and more than 1.5 mm in females in leads V2, V3. In the other leads, if it is more than 1 mm elevation. So, every ST segment elevation is not a myocardial infarction. So, let us understand what are all the causes for ST segment elevation. So, we have a STEMI, we have pericarditis. In pericarditis, what is the type of ST segment elevation you get? You get a smiling face pattern. You get a smiling face pattern and it is diffuse. It is diffuse. Then what is a Brugada syndrome? What is Brugada syndrome? So this is an inherited condition. This is an inherited condition which is characterized by resting. During rest there is a ST segment elevation which can have a coved ST segment elevation. You can have a coved ST segment elevation or you can have a saddle back ST segment elevation. So this is about the patterns that we are talking of. So this is your coved ST segment elevation or a saddle back ST segment elevation. So what happens in this Brugada syndrome is that it is inherited in an autosomal dominant fashion, and it is more common in males, where in young males they have nocturnal agonal respiration. They have nocturnal agonal respiration. They have nocturnal agonal respiration which leads to death. Because of what? Because of a massive ventricular tachycardia. Okay, because of a fatal VT. So, the Brugada syndrome is an inherited condition which basically predisposes to fatal VTs, and this also can present as ST segment elevations on the ECG. Then we have hyperkalemia, hypercalcemia and LV aneurysms. LV aneurysms are formed when post-MI, persistent ST segment elevation, you have to think of LV aneurysms. So that is about the different causes for ST segment elevation. So with this we have understood the abnormalities of the ST segment. Now let us understand what is the U wave. We have already looked at it in our discussion of the basic ECG. U wave occurs due to repolarization of the bundle of His, and it is seen in hypokalemia. It is seen in hypokalemia. Okay, fine. Now let us look at the next important aspect. How do you calculate the heart rate? How do you calculate the heart rate? Let us look at the next important aspect, how to calculate the heart rate. Okay. So the heart rate is given by the formula 300 by number of large boxes or 1500 by number of small boxes between what? Between two QRS complexes. Between two QRS complexes. So if you look at this ECG, how many large boxes are there? So how many large boxes are there? It is 4. So it is 300 divided by 4. So 300 divided by 4 gives you the heart rate. Okay. So 300 divided by 4 gives you the heart rate. Or in terms of small boxes, you will tell it as 1500 divided by number of small boxes. Okay, 1500 divided by number of small boxes. So the normal heart rate is between 60 to 100 beats per minute. If it is more than 100, we call it tachycardia. And if it is less than 60, we call it bradycardia. So in this ECG, what is the heart rate? It's approximately 75 to 76 beats per minute. So will we say this is tachy or brady? No, this is a normal ECG. Okay. And what do you mean by this term sinus? We call it as a normal sinus rhythm, right? What do you mean by this term sinus? So if every P wave is followed by a QRS complex, every P wave is followed by a QRS complex, then we call it a sinus rhythm. Okay. Fine. Now what happens when the heart rate is irregular? What happens when the heart rate is irregular? Then you have to see the number of QRS complexes in 6 seconds and multiply it by 10. So the formula that you have to use in an irregular heart rate is number of QRS complexes in 6 seconds multiplied by 10. Okay. So till now what all have we learned? We have learned about the various waves in the ECG. We have found out how to find the heart rate. We have found out the various abnormalities and various waves of the ECG. Now let us understand the next portion, which is very important, is your axis of the ECG. So what do you mean by the axis of the ECG? Axis basically means the overall direction of the electrical activity of the heart. So, the overall direction of the electrical activity of the heart is denoted by the axis of the ECG. So, let us understand this with the help of this line diagram. So, this is your heart, it is taken up in a cross section, So, this is anterior, posterior, left and right, correct? So, if the heart is like this, if this is the normal direction of the heart, this is anterior, posterior, left and right. So, this is what is shown in this diagram, okay. Now, what do you think will be the normal electrical activity or normal axis? It will be this way, fine. So, it will be this way. This is given by what? If you put it in a vectorial diagram, you look at 0, 180 degree, 90 degree. So, it will be somewhere here. This is the normal electrical activity. So, minus 30 to plus 90 degree is what we call as the normal electrical activity of the heart. This is what we call as the normal electrical activity of the heart. Now, in certain conditions, suppose there is a left ventricular hypertrophy. This is the heart. If there is a left ventricular hypertrophy, the vector will move more leftwards. If the vector moves more leftward and the heart is rotated slightly leftward, then what happens? What happens to the axis? Axis becomes left axis. So, if you just put it here, now there is a chamber enlargement, basically your LV is enlarged. So, what happens to the electrical vector? The normal electrical vector shifts leftwards, right? Depending on the degree of the shift, the electrical activity will shift leftward. So, this is what is your left axis, right? So, we can say that from minus 30 degree to here is your left axis, right? So, this is your left axis. Similarly, if there is a right ventricular hypertrophy and the heart is shifting this way, okay, then what can we see? That this axis in this quadrant from 90 to 180 degree is your right axis, and this is your extreme axis, which is very, very rare. So, this quadrant is your extreme axis, which is very, very rare. Alright. So, this is on the whole what exactly is your axis. Okay. Alright. Now, which leads are used? To find out the axis of the heart? It is your limb leads or the frontal plane. Now, we know that from the hexaxial reference system that the frontal plane is represented by these leads, okay. And how is the heart placed? The heart is placed something like this. So, what is the normal axis if you represent here? The normal axis will be from here to here, okay. So, the net electrical activity vector is anywhere in this much degrees between this quadrant to this quadrant. It is a normal axis, okay. So, we have understood till here. Now, the method which is used, there are 2 to 3 methods which are used to calculate the axis of the heart, but the easiest method is what we will be learning for today. So, the easiest method is using the quadrant method. So, what is this quadrant method? So, we use the net electrical activity in 2 leads. Which are the 2 leads? We use 2 leads which are perpendicular to each other. So, we use 2 leads which are perpendicular to each other. So, let us say lead 1 and AVF. So, we use lead 1 and AVF. And what are we looking at? We are looking at the direction of the QRS complex. So, we are looking at the direction of the QRS complex. Now, let us take the first scenario, okay. Now, in the first scenario, the QRS complex in lead 1 is positive. Okay, the QRS complex in lead 1 is positive. So, this is your lead 1, this is your AVF, this is how it is represented. So, you have a positive wave in the QRS complex means which quadrant is the vector representing? It is representing this quadrant. Okay, fine. That means electrical activity is this way. Now, in AVF, in the lead AVF which is at 90 degrees to that, also the QRS complex is positive. So, which quadrant is that representing? It means it is along this direction. Okay. So where is the overlap happening? It is happening here. What is the net electrical vector direction? It will be along this direction. Correct? It will be along this direction. And what does this mean? This is in which axis? This is your normal axis. This is your normal axis. Now let us look at the second situation. Now in lead 1, the QRS complex is positive. So this quadrant is involved, it is positive. In lead AVF, however, the direction of the QRS complex is negative. Negative means where? It is here. It is along this direction, and you are getting a negative deflection. So where are you getting this overlap? The net electrical vector direction is here. Okay. And which quadrant does this belong to? That means this is your left axis deviation. This is your left axis deviation. Fine. Let us look at the third scenario. Here the QRS complex in lead 1 is negative. That means where? It is towards this direction. So this quadrant, and in AVF it is positive. So it is in this direction, right? So where is your net vector? It is here. Net vector here means what? This is your right axis deviation. This is your right axis deviation. Okay. So can you see from here? Can you see from here? This same diagram we will draw here. Alright. So this is your normal axis. This is your 0, 180 degree plus 90 degree. This is your minus 30 degree. So this is your normal quadrant. This quadrant is your left axis deviation. This is your right axis deviation, and this is your extreme axis deviation. So this is what we have obtained here. The net electrical activity is normal here. This is your left axis deviation, and this is your right axis deviation. Now we will look at certain ECGs and you will get this better clear. Let us look at the first ECG. Let us look at the first ECG. Now how do you determine the axis here? Which two leads you will be looking at? You will be looking at lead 1 and you will be looking at lead AVF. What is the net electrical activity of lead 1? It is a positive complex. So lead 1 positive, and in lead AVF what are you seeing? You are seeing negative. Okay. Now we had just seen, if you draw here lead 1 in AVF, positive here is here, negative here is here. Where is the overlap? So this is your left axis deviation. Fine. So this is your left axis deviation by the quadrant method. Now can you see this ECG? Here, what is the lead 1? It's a predominantly negative complex, and lead AVF is a predominantly positive complex. Okay. So in lead 1 and AVF, negative in lead 1 is here and positive in lead AVF is somewhere here. Net activity is your right axis deviation. Okay. So this is how you find the axis of the ECG, or the overall direction of the net electrical activity of the heart. Fine. So that is about the axis of the ECG. So finally we learn how do you interpret a normal ECG. Finally we have learned how do you interpret a normal ECG. So first thing that you have to do is always check the standardization. In every ECG it will be written that 10 mm is 1 millivolt. 10 mm is 1 millivolt is a standardization. Look for the rate. How do you calculate the rate? It is 300 by number of large boxes or 1500 by number of small boxes. Then you look at the rhythm. The strip, which is your rhythm strip, is your lead 2. Rhythm strip is your lead 2. You look for the rhythm. Then you look for the axis. Then you look at the waves. You see your P wave, QRS complex, T wave. If each P wave is followed by a QRS complex, we call it a sinus rhythm. Then you look for the intervals, you look for the progression of R waves, you see the ST segment and the U waves. So this is how you should ideally report an ECG. Always go in the given particular order so that you do not miss any of the changes or any of the pathologies. Okay. So this brings us to the end of our discussion on a normal ECG. I hope you have understood clearly how each and every wave of the ECG is formed. In further sessions, we will be learning about chamber enlargement, hypertrophy, bradycardias and tachyarrhythmias. Okay. So, see you in the next session. Thank you.